Hello, everybody. We are so excited to have Dr. Gaby Frank with us today, talking about this fascinating topic. Many of you know her. She's a hospitalist and a professor of medicine at the University of Colorado School of Medicine and the medical director for Denver Health's Bio-Containment Unit. She's also a subject matter expert for the National Emergent Pathogens Training and Education Center, serves on a number of fascinating committees, published extensively around emergency preparedness and emerging pathogens. She's also the director of faculty development and advancement for her division of hospital medicine, the co-director of the Mid-Career Women in Leadership Program, the co-chair for the DOM Expert Council for Clinical Excellence and Leadership, and a member of her school's Academy of Medical Educators. She just returned from a number of national conferences, and we are so excited to have her with us. Dr. Frank, take it away.
Thank you for the introduction. I usually introduce myself. Hi, I'm Gaby. So if you have any questions, feel free to say, hey, Gaby, blah, blah, blah. I totally fine with it. So I'm going to skip the introduction, but welcome to the talk today. The whole plan is to try to discuss the status of emerging infectious diseases outbreaks and the potential for US cases. We're going to review the diagnostic and clinical highlights of the current and recurrent infections and emerging diseases, and we're going to explore the role of clinicians and frontline healthcare workers in the management of biosafety level 3 and 4 patients. I do have no financial conflict of interest to disclose. So for those of you who actually practice infectious diseases, a lot of the information in the talk is probably going to be redundant for you, but maybe it's a way for you to understand how we can help partners that don't do infectious diseases to actually become more proficient in dealing with these patients if they come to any of our institutions. So as a way of introduction, I don't know if all of you are familiar with NETEC, that is the National Emergent Special Pathogens Training and Education Center, previously known as National Ebola Training and Education Center, but luckily we changed the name. And soon is to be moved to the National Special Pathogen System that is going to be similar to it, like the trauma centers tier levels. But as of now, in the United States, we have 10, and now as of this year, we're going to have 13. So there are 3 new centers that are being onboarded as regional emerging special pathogens treatment centers. So we used to have 1 per HHS region, and now we have 2 centers in region 3 and 2 in region 5. Your regional emergent treatment center is at Bellevue in NYU, the one that is closest to you. So basically the way that this system is organized, we have some frontline healthcare facilities that we have almost 5,000 of those in the country, or at least we did before COVID, and then we need to retrain a lot of these institutions. But basically they should be able to stabilize and treat and transfer those patients to either a treatment hospital or regional treatment facility. Besides that, like that's all they're supposed to do, like stabilize and transfer. And then we have assessment hospitals that we are a little above like 200, and those hospitals are supposed, and maybe you're one of these or one of the treatment hospitals, to be able to treat a patient with an at this point a viral hemorrhagic fever for up to 96 hours until the patient can be transferred to, again, treatment or regional treatment center. And then we have around 60 treatment hospitals. And as I said before, as of this year, we have 13 regional emergent special pathogens treatment centers. I already mentioned what NETEC stands for, but basically what they're trying to do is to set the gold standard for special pathogens preparedness and response across the health systems in the US, with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. Something for you to keep in mind is that there's a lot of different areas of focus, and they can provide resources to any institution dependent of your denomination or designation. And there's a lot of free resources within NETEC website if you want to visit it. So I'm going to say the majority of you, this is not going to be news, but you know that there's different pathogens categories and biosafety levels. So we have category A, B, and C pathogens, and this is per NIAID, emerging infectious diseases, that they do this denomination in collaboration with the Department of Defense as well as the CDC. So basically, Category A pathogens are those organisms or biological agents that pose the highest risk for national security and public health. They're easily disseminated and transmitted from person to person. They have high mortality rates. They might cause public panic, and they require special action for public health preparedness. And then we have on the other extreme, the category C, that these are the third highest in priority, and they usually include emergent pathogens that could be engineered for mass dissemination in the future, but currently are not considered at that risk. They're easily available. Have some ease of production and dissemination, and they have the potential for high morbidity and mortality. And then in the middle, we have category B. And why am I talking about this? And it's basically because we're setting the scene to what we're going to be discussing about the viral hemorrhagic fevers. So for the category A, this is the big pathogens. So we have some bacteria and toxins, as well as some viruses. We have all of the filoviruses fall under this category, all of the arenaviruses, some viruses, and flaviviruses such as dengue, but because it's not transmitted from person to person, usually we don't use our bio-containment units to treat patients with dengue, as well as Hanta. So, and again, these are some examples of category B and C pathogens. We see that for category B, we have some bacteria and toxins, some food and waterborne pathogens, and mosquito-borne viruses. And for category C, we have Nipah and Hendra viruses, tick-borne and hemorrhagic fevers, and encephalitis viruses, tuberculosis, some of the Vera coronaviruses, which used to be a different category before, but after our experience with COVID, this were changed to a category C, some prions, some other pathogens as well. So when we talk about the biosafety levels, we go from biosafety level 1 to 4, and that goes from low risk to very high risk microbes. And we can see for biosafety level 1, although we're required to use our gloves, and that's an example of those is the non-pathogenic E. coli, all the way up to filoviruses such as Ebola, and what we need to use our whole PPE. And just to keep this in mind, more than 60% of the emergent diseases are zoonoses. So we always need to try to either know where to go and find it if we don't have it in our brain, but just to keep in mind what are the vectors and reservoirs for each of those pathogens. So when we actually take a history and physical, it can actually lead us to what is in our differential and what the exposures for the person are. So the returning traveler, and this is where it gets interesting. So I usually ask for a show of hands of how many of you actually enjoyed an international trip in the last year. And I'm not going to see a show of hands, but probably the majority of you in the last year had some international travel. So just to give you a number, there was 79.3 million international air travelers in 2019 that arrived to the US. That is a lot of people coming back from another country. Again, a lot of them are not going to have any exposures of interest, but you think about it, that is a lot of people. There was a decline of international travel, of course, between 2020 and 2022, but the expectation that is for 2023, we're going to have a very similar number to what we had in 2019. So again, this goes to, and again, you're all in New York, so you have a lot of airports with a lot of people coming from a lot of different places. So let's try to use the scenario. You are called by the emergency. Let's assume you're a hospitalist, so you're in the inpatient unit, and you're called by the emergency department to admit a 23-year-old patient. Patient has a fever and recently returned from Africa. That's all you hear. Reports returning to the US 6 days ago, 2 days after arrival to the US, the patient developed a flu-like syndrome with myalgia, fever, and headache. And since yesterday has been having abdominal pain, nausea, vomit, and diarrhea as well. Physical exam is non-contributory other than dry mucous membranes. And the significant laboratory findings include a potassium of 2.9, a Y count of 11, and a mildly elevated ALT and SAT. So you have this case, you listen to this on the phone, and you're like, okay, based on the information that I have, my patient is going to have a viral hemorrhagic fever, malaria, typhoid fever, cholera, or other. Like, let's assume we are, for example, in respiratory season, so we can think of influenza, COVID-19, non-tolerance travelers, diarrhea. So this patient can have a lot of different things. And this is where it gets tricky, right? With like that basic history, we cannot actually get a good differential diagnosis because it could be anything. And this is something to keep in mind about viral hemorrhagic fevers. The presentation is very non-specific in the beginning, so we truly depend on our history. So because you're all internists, usually you're going to be like, okay, this information is not enough for me, and I want to know a lot more about the trip. So what are the countries and cities that the person visited? What are the days that the person stayed in each country? What was the trip about? Like, was it a tourist trip? Did they go to do safaris? What were the exposures during that trip? Was there any exposure to animals? Did they drink potable water all the time? Was there any sick contacts? Did the patient use any malaria prophylaxis? What is the immunization status? So there's so many things that as internists we're going to ask ourselves. So basically the patient was a 23-year-old botanical sciences PhD candidate, spent 6 months at Obudu Mountain Resort in Nigeria. 2 weeks before returning to the US, visited Kibale National Park in Kampala in Uganda, returned to Lagos for 2 days before returning to the US, used mostly clean water, had contact with chimpanzees, adhered to malaria prophylaxis, and the immunizations are all up to date. This is including yellow fever, but there was the patient did not receive Ebola virus vaccine. And we'll get to what vaccines are available to people. So now we have a little more information on what the exposures could potentially be, but this is something that our colleagues in infectious disease are very, very good at, is taking very good epidemiologic history. And I'm going to argue that whenever we're admitting a patient that is a return traveler that comes with non-specific symptoms, we need to be as good as our infectious diseases colleagues and taking a good history. So our epi history should include what was the resident of the patient, where were they staying, what is the occupation, what is the travel, what are the animals' exposure, sick contacts, burial practices, and everything within the last 3 weeks. So you're going to see this recurrent number, like 3 weeks or 21 days in most of the viral hemorrhagic fevers that we're going to be discussing, except for CCHF. But the 21 days is going to be the magic number at this point. And if you don't remember that one of them is 7 days, stick to 21 days exposures, because that's what we want to know. So when we think about this, again, our differential is still very, very broad, but what's going to help us narrow it a little is all this epi history that we're going to be obtaining from the patient. So before I ask you, now that you have this information, what do you think the patient has? We're going to be discussing viral hemorrhagic fevers a little more. So the CDC has a case definition for viral hemorrhagic fevers, and we have some clinical criteria, laboratory criteria, and epidemiologic linkage. And basically, in order to suspect, we need to meet the clinical criteria and an epi criteria, and in order to confirm it, it needs to meet the laboratory criteria. So when you think about the clinical criteria, look how non-specific this is. So the patient has to have an acute onset of fever and one or more of the following. And this is like severe headache, myalgia, maculopapular rash, vomiting, diarrhea, abdominal pain, bleeding, and not related to injury, which this is late on the disease. So it's not what we're going to see right away on the patient. Thrombocytopenia, pharyngitis, and this is mostly for Lassa fever and Venezuelan hemorrhagic fever, not for all the other viral hemorrhagic fevers. Some proteinuria, retrostomal chest pain. So you can see how the clinical criteria is like not very helpful. Most of the patients that I admit have this, so I need more than this. So that's where the epi linkage actually comes into play, and they have to have one or more of the following exposures within the last 3 weeks before the symptom onset. Again, magic number, 3 weeks or 21 days. And they need to either have contact with blood or other bodily fluids of a patient with a hemorrhagic fever. They need to have residence in or travel to a viral hemorrhagic endemic area or an area with an active community transmission. Work in a laboratory that handles viral hemorrhagic fever specimens, work in a laboratory that handles bats, rodents, or primates from a viral hemorrhagic fever endemic area or an area with an active transmission, and have to have had a sexual exposure to semen from a confirmed acute or clinically recovered case of viral hemorrhagic fevers. And we're going to get back to that, but there's a lot of literature about having viable virus in semen up to 12 plus months after recovery from Ebola. So this is something that is actually very important to keep in mind and ask when we take our history. And then the laboratory criteria, this is what's going to make our suspect case into a confirmed case. We need to have some detection of the viral antigens in blood, by ELISA or viral isolation in cell culture. Do not try to do this at home. This gets to be done in a VSL4 laboratory. We need to have detection of the viral specific genetic sequence by PCR from bladder tissue, and detection of the viral antigens in tissue by immunohistochemistry. So when we talk about Ebola virus, we can see that there's 6 different described Ebola viruses, 4 that are known to cause disease to humans. The most common, or the ones that cause the majority of the cases, is the Zaire Ebola virus that has a mortality between 50 and 90%. It was first described in 1976 to be causing cases in humans in the Democratic Republic of Congo. And we can see how we had some different outbreaks, with the latest one was between 2018 and 2020. The latest Ebola outbreak, however, was from the Sudan Ebola virus and was in 2022 in Uganda. And that's when I say Kampala for the clinical case, because there were some concern for community transmission in Kampala. And this has a mortality of 50 to 60%. We have the typhus Ebola virus that has a mortality of 0%. There was only one small outbreak in 1994 in Cote d'Ivoire. And the Bundibugyo Ebola virus that has a mortality of 25%. And there was a single outbreak in 2007 in Uganda. So when we think about Ebola virus in the clinical presentation, the incubation for all Ebola viruses between 2 and 21 days. Again, here's the magic number of 3 weeks of 21 or 21 days. Usually the incubation period is symptomatic and is non-contagious. From there, the patient is going to have some dry symptoms, and it's what we call the dry stage that lasts between 1 to 4 days. And that's like a flu-like syndrome, right? The patient can have fever, myalgia, arthralgia, and headaches. From day 4 and onward is when the patient usually is going to have wet symptoms, and that is nausea, vomiting, and diarrhea. Only 50% of the patients will actually have hemorrhagic symptoms, and that is late in the disease. And a lot of the patients will have a very prolonged convalescence period with multi-organ symptoms. The most common laboratory findings are going to be leukopenia, lymphopenia, and transaminitis, as well as during the wet symptoms, a lot of electrolyte abnormalities. This is a different table that goes a little more detail in what the different findings are in each of the different stages. Again, incubation is thoroughly asymptomatic. We're going to have the early febrile or dry symptom or dry stage, wet stages, and then usually those patients who are going to have fatal disease are going to develop shock, and they can have any other complications. And the convalescence is months to year with many, many non-specific symptoms. What is important for this convalescence period is that the patients can have persistent positive PCR in certain body fluids, such as all the ocular fluids, CNS, like CSF, breast milk, and semen. So this is something to actually keep in mind if somebody needs to have, for example, an elective cataract surgery, right? A couple, like a year after they recover from Ebola, it's like, do we need to keep checking the patient? And to be honest, I'm throwing this out there, but there's no real recommendations on what to do. It's something that we need to be cognizant of, and maybe have a very good discussion with the surgeons and whoever is going to be taking care of those patients. And as you saw before, when we talk about the convalescent, this is a nice article from Bond that actually describes all the different symptoms that can affect almost any organ in the convalescent period. And you can see the arrow on the right-hand side that actually shows the contagiousness. So the patient has the highest number of virus at the end of the disease of when they have hemorrhagic shock. So even after death, the patients are very, very contagious, and that's what the burial practice is one of the very important things that we need to obtain from our medical history and epi history on those patients. Before I talk about diagnosis and treatment, I decided to move just through Marburg virus. That is another of our filoviruses, since the diagnosis and treatment is gonna be somewhat similar. So Marburg virus, the first human infections were detected in 1967. And when I talk about Marburg virus, you're all aware that this is a current outbreak in Equatorial Guinea and Tanzania. So Tanzania is currently in the countdown, the 41 days to count down to say that they don't have any more cases, but Equatorial Guinea actually closed the doors to WHO, so we don't have a lot of information of what's happening in Equatorial Guinea right now. But every single one of their districts are having cases. So again, the first cases were in 1967 in Germany and Yugoslavia, and there were 31 cases and 7 deaths, and that was related to importation of some monkeys that were being used for production of poliovirus vaccine. And then since then, there were over 600 cases in different small outbreaks, and as I said, the latest one is the one that is happening right now. The case fatality rate is 23 to 88%. This latest outbreak was above 80%. The mortality in all the people that are going to be at risk are going to be the household contacts and healthcare workers. When we talk about the clinical presentation, again, incubation of 3 to 21 days. And during this phase is asymptomatic and non-contagious. And usually the patients after the incubation are going to have an abrupt onset of non-specific symptoms such as fever, chills, sore throat, myalgia, vomit, and diarrhea. A lot of these patients will develop a non-pruritic rash, and you can see in the picture on the left-hand side that is non-pruritic, is maculopapular erythematosus, blanching, and diffuse and confluent. And a lot of these patients will actually develop conjunctival injection that is very characteristic for Marburg disease. They're going to have extreme temperature fluctuations, and tachycardia is more common in fatal cases. And the hemorrhagic manifestations are late in the disease with mucosal bleed, is a bruising and persistent bleed from venipuncture sites. Most of the mortality cause is from renal failure and shock, as well as multi-organ failure. As well as for Ebola, there is no evidence of asymptomatic infection. So if a patient gets exposed and contract the virus, they're going to develop the disease, which doesn't mean that they're going to die from it, right? They can have like a mild disease and recover, but there is no current evidence about asymptomatic infection. So talking about filoviruses diagnosis, and this is, you know, when we discuss first the table about the laboratory criteria, basically we can culture the virus. Again, this should not be happening in any of our hospitals. The culture will be happening at VSL4 laboratory. We can do serology, we can do PCR, immunohistochemistry, and the samples that we can use for our blood, bodily fluids, and tissue. So I'm going to say that all the regional treatment centers, those 10, soon to be 13, we all have the warrior panel, so we can actually do PCR for Ebola in our institutions, but it needs confirmation at the CDC. So usually we also need to send samples to the state public health as well as CDC, and we need to repeat at 72 hours. So we need at least 2 samples 72 hours apart to either say that it's a negative or a positive. And the U.S. Army Research for Infectious Diseases, Research Institute for Infectious Diseases can also test it. So how do we prevent getting exposed to, the first thing is decreased transmission. So we need to minimize sexual transmission, particularly when during an outbreak in people who are recovered, burials, and minimize the epizootic cycle. So when we talk about pre-exposure prophylaxis and what vaccines do we have available, at this point, there's 2 licensed vaccines for Ebola. The only one that is approved in the US is Ervivo, and it's only effective to prevent Zaire Ebola virus. That is the one that actually has the highest number of cases. In Europe, they have Vavia approved. That is a Johnson & Johnson vaccine that has 2 doses. The first dose is protective against Zaire Ebola virus as well as Ervivo. And the second dose is a quadrivalent that actually will protect against Zaire and Sudan Ebola virus as well as Typhus and Marburg virus. This one, even though we would like to have it, is only available in Europe right now, and we don't have it available in the US. But for all those people that actually work in laboratories and regional treatment centers, we have Ervivo available for them to receive. When we talk about post-exposure prophylaxis, as I said before, most of the cases were from Zaire Ebola virus. So most of the research is done with Zaire Ebola virus. And we can actually do Ervivo, that is the vaccine after exposure, and that is known to be effective for post-exposure prophylaxis, as well as Inmazeb. And we'll get to Inmazeb in the next slide. That is when we're talking about the treatment. For Sudan Ebola virus, Ervivo, again, is not effective, and if we are in the US, we don't have Vavia in the US. That being said, there's some phase 2 monoclonal antibodies that are being tested right now. And again, the regional treatment centers have it available in case we get any case of Sudan Ebola virus. Same thing with Marburg. We do not have the Johnson & Johnson vaccine to actually do the vaccination after exposure. That being said, we do also have some monoclonal antibodies that are phase 2 that we could use as a EIND for our personal or any repatriated healthcare worker that want to take care of Marburg cases at this point in Equatorial Guinea. And again, before is, if we actually were to have a patient, what is part of our discharge instructions, if they are male, is to, when they're having intercourse, to actually use a condom to tie it and throw it in bleach before disposing of it. And we recommend to do that up to a year, or to have 2 consecutive negative PCRs in semen. So that's actually part of our discharge instructions to try to decrease transmission. So how do we treat these patients? The main thing that we do is supportive care, right? And not all the patients will need ICU care. That being said, the sicker the patient gets, the more viral load they're going to have, and the more chances that any of our people that are taking care of those patients can get exposed despite our PPE. And we know that, accidents happen, so we try to minimize exposure. So we try to do early central IV access, and that is also going to minimize the venipunctures that we do to the patients to draw blood, and be able to do fluid resuscitation very aggressively, particularly when the patients are on the wet phase. So we try to do early central IV access. We're going to do fluid replacement and, the blood products as needed, electrolyte monitoring and replacement, respiratory support. And we do low threshold sedation. And this is the same thing. We need to keep our healthcare workers that are at the bedside of the patient as safe as possible. And if the patients, actually, a lot of these patients will have some encephalopathy during the acute phases, and they may get agitated. So we need to make sure that where they're not touching, and like we do a lot of tests with glow germ and how many high touch surfaces we have in the room. So we need to minimize exposure again of our personnel. We're going to do symptom management. And again, these patients, as any other patient that is critically ill, can have secondary bacterial infections. So we're going to test and treat accordingly. So when we talk about Ebola virus and medical management, and there was the PALM trial, and probably a lot of you heard of it. It was published in the New England. In the PALM trial stands for Pamoja Tulinde Maisha, that in Swahili, that actually stands for Together Save Lives or Protect Lives. So I thought it was a very cool name for the trial when we translated to English. So basically, the PALM trial was a 4-arm trial, again, against Zaire Ebola virus, and they were tested remdesivir versus Inmazev versus Ebanga versus ZMapp. And it was very obvious during early in the treatment that the 2 arms that have Inmazev and Ebanga have a lot better response or a lot better outcomes than those patients on remdesivir and ZMapp. So basically, remdesivir and ZMapp were dropped from the trial, and they continued with Inmazev. So Inmazev is a Regeneron cocktail of monoclonal antibodies. Ebanga is only 1 monoclonal antibody. And again, ZMapp was 3 chimeric monoclonals, and remdesivir you're all familiar with after COVID, but it's an RNase polymerase, RNase-dependent inhibitor. So, and again, they used to do convalescent plasma, but not anymore. So this is all we have for Zaire Ebola virus. And as we said, like Inmazev is actually FDA approved in the US. And in order to get it, it needs an EIND, and the CDC stores it. So basically, if you have a patient with Ebola that you want to do Inmazev, you need to request it through CDC. For Sudan Ebola virus, as I said, we don't have any antivirals approved at this point. Inmazev is not active against Sudan Ebola virus, but we have MVP134, that is the one that I told you that is a phase 2. And that is the one that we potentially have available in all of the regional treatment centers if we were to have a patient with Sudan Ebola virus, similar to Marburg. That is the MR191, that is the monoclonal antibody against Marburg. Again, phase 2 available as an EIND. So moving on to arenaviruses. That was a lot on filoviruses, but moving on to arenaviruses. So we have 2 big groups, the old world arenaviruses and the new world arenaviruses. So some of you may have noticed I have an accent, and I didn't address that before, which is very peculiar because I usually say, oh, by the way, I have an accent because I'm from Argentina. So if you don't understand what I'm saying, just ask a question. I'll say it again in with the same accent. But anyways, So the New World arenaviruses are usually also known as South American hemorrhagic fevers. And then we have the Old World arenaviruses such as Lassa and Lujo virus. They're the ones that you're probably more familiar with. So when we talk about Lassa fever, again, we have this very lovely reservoir that is the Mastomys natalensis. And we can see how Lassa is actually endemic in some areas in West Africa. So you can see in blue and green, the countries where they have continuous cases, of those countries where they have had some cases and they have the reservoir, but they don't have ongoing cases. So one of the things that I'm going to say about this rodent is that usually goes to the residence of patients in a way and eats their food. So one of the big things to prevent this is how the food is stored in the homes, and ask about the residence conditions is very important to assess for exposure to the rodent excreta. So basically, before I go to incubation, the way that it's transmitted, so the rodents have live viruses in their urine and feces. So basically, the way we get it is from aerosolized excreta from the rodents. So if there's some excreta in the domicile of the patient, that's how they can actually get exposed to it. So usually the incubation period is 2 to 21 days. As I said before, 21 days is the magic number. After they get exposed, they're going to have an incubation that is asymptomatic. And the difference between Lassa virus or arenaviruses and the filoviruses that we just discussed is that a lot of these patients can actually have a very, very clinical spectrum. They can go from totally asymptomatic to have a fatal viral hemorrhagic fever. So 80% of the patients that actually acquire Lassa virus are either going to be asymptomatic or they're going to have a very mild disease. Whereas 20% of those patients are the ones that are going to have more significant or severe disease. And the fatality is 1% when we account for all cases, but it's 15 to 20% of the hospitalized patients, those that get sick enough to actually get hospitalized. It's important to know the pregnancy infections, and they can lead to congenital infections, and those are actually more severe. But we can see how, again, the initial symptoms are fever, malaise, headache, vomiting. Different to other infections, we can see that these patients can have facial edema, and 70% of the patients with Lassa virus will actually have some pharyngitis. And a lot of the patients can have bleeding, ARDS, multi-organ failure, and shock. And usually the whole disease course is for about 2 weeks. A lot of these patients will develop some neurologic symptoms such as hearing loss, tremors, and encephalitis. And one of the most common sequelae is deafness that is present in up to 33% of the patients. So when we think about special populations, and I told you the Lassa virus infections were a little more severe during pregnancy. And basically, they do have high mortality during the 3rd trimester with 95% of fetal mortality. And they have a very, very high rate of spontaneous abortion. Pediatric cases are also thought to be more severe. And the swollen baby syndrome in congenital infections has a fatality rate of 83%. The sequela, as I said before, the most common is sensory neural hearing loss. That is up to 33% of the patients. And a lot of patients can have some ophthalmological abnormalities, aphasias, hair loss, balance impairment, including some cerebral ataxia, delayed onset paraparesis, and there's again abortion and fetal demise, and a lot of social stigma. And if you go to the CDC website on Lassa virus, you're going to see a lot of some of the drawings are from the CDC website that are here on the bottom. You can see a lot of drawings from kids actually that demonstrate the stigma of Lassa virus in their communities. Same thing that we did with filoviruses. I'm going to talk about all the significant arenaviruses and then go to diagnosis and treatment. So when we what?
May I ask a question?
Yeah.
What's the incidence of Lassa virus in these communities?
What is the incidence?
Yeah, how common is it?
It depends on the, there's an outbreak, like Nigeria has constant cases, but I don't know the exact number of the incidents because 80% of the patients are actually asymptomatic or have minimal disease, so they're not being seen. So it's hard to attest for the true incidence of the disease.
Thank you.
But the country that has constant cases is Nigeria. And if you go to the Nigerian CDC, they have a very nice website and they have a very updated number of cases per year, but usually they only track the hospitalized cases. So when we talk about the South American hemorrhagic fevers, again, they are arenaviruses, and these ones are the newer arenaviruses. And we can see again, the reservoir are rodents, and the way of acquiring it is very similar by exposure to excreta of these rodents. The difference between Lassa rodents and South American hemorrhagic fevers is that these rodents are mostly in the fields, so farmers are the ones that get exposed, whereas the other rodents that are more related to Lassa actually they are in the vicinity of the homes or inside the homes of the patients. So there's at least 5 different South American hemorrhagic fevers, but the 3 most common, on the ones that have the high number of cases, are the one caused by Junin virus, that is the Argentinian hemorrhagic fever, the Machupo virus, that is the Bolivian hemorrhagic fever, and the Guanarito virus, that is the Venezuelan hemorrhagic fever. So in case you forgot the 21 number, the incubation again is 3 to 21 days. They're usually going to have a prodrome phase that is from days 1 to 6. That again is very non-specific with fever, malaise, flu-like syndrome. They're going to have the illness phase that usually goes from day 7 to 12. In this, the patients will have some GI and neurologic symptoms, plus or minus some hemorrhagic symptoms. As we said before, most of the patients will not develop hemorrhagic disease. And then the convalescent phase that is up to 3 months. And in the case of Argentinian hemorrhagic fevers, particularly in patients that were treated with convalescent plasma, can develop a late neurologic syndrome that can happen up to 4 months after recovery from the disease. So again, in order to diagnose it, we need to do a very good history and take account of the epidemiologic exposure, as there's very specific areas of where these rodents are and where there is presence of disease. We're going to think about the clinical spectrum, the special population. So in infection during pregnancy has a 50% case fatality rate. Children tends to have milder disease, and the late neurologic syndrome, as I said before, this usually happens in up to 10% of the patients that receive convalescent plasma for treatment, and is known for Argentinian hemorrhagic fevers, not for the other South American hemorrhagic fevers. And it usually presents with dizziness, headache, nausea, fever. Cranial nerve palsy is up to 60% of the patients. Sorry, that's not supposed to be the little thing there. Several deficits are up to 50% of the patients, as well as tinnitus and blurred double vision. The thing is that is reversible, right? All the symptoms are present for a while, and then with physical therapy, most of the symptoms actually resolve. And the case fatality rate is 23 to 35%. So how do we diagnose arenaviruses? And again, when we think about the criteria for viral hemorrhagic fevers, this is the same to all viral hemorrhagic fevers, not just for filoviruses, but it's the same for arenaviruses. So we're going to think about the clinical presentation. Again, you can see that it's very, very non-specific. The epidemiologic exposure or that epidemiologic linkage is what's going to make the case actually for a viral hemorrhagic fever, and then we need the confirmation by laboratory criteria. It's important to know that the viremia declines during the 2nd week of illness. So in those cases, we may need to do serology, but usually if we suspect this early, we can do PCR from samples such as blood and oropharyngeal swabs. Sometimes you can actually test it in urine and CSF, and we're going to look for seroconversion. So when we talk about pre and post-exposure prophylaxis, for the Argentinian hemorrhagic fever, actually there is a vaccine. That is the counted #1 vaccine. It's a live attenuated vaccine for the prevention of Argentinian hemorrhagic fever. The cases went from having many thousand a year to have less than 14 in many years. So the vaccine actually only the people that live in endemic area and our farm workers actually are offered the vaccine. They stopped giving the vaccine in 2018 because the cases were almost 0. That being said, the cases went back up. So in 2021, they restarted the immunization campaign for people who live in endemic area. It's a single dose and is only offered, as I said before, to people who would be exposed, but it's very, very effective. There's no vaccine for any of the other South American hemorrhagic fevers. And for Lassa virus, there's multiple vaccine candidates at this point, but none of those are approved. For post-exposure prophylaxis, there's nothing that is approved, and there's all ribavirin off-label use. But they will still use it, and you will find a lot of papers, particularly for Lassa virus, using ribavirin, plasma and favipiravir for post-exposure prophylaxis and for treatment. That being said, they're not FDA approved for this use. But the main thing, particularly for South American hemorrhagic fevers, and the same thing for Lassa virus, right, is avoid the environmental exposure. So for Lassa, we need to actually do a lot of education on how to maintain the food in the house and how to prevent rodents from being in the homes. And then here is for South American hemorrhagic fevers is how they get dressed to actually work in the fields and maybe wear masks so they don't get to inhale any of the rodent excreta. For treatment, this is very similar. We're going to be supported therapy, and all of the antivirals are off-label use. So ribavirin is used for most of the RNA viruses, but again, they are not approved for this, but they can be used as an off-label use, and all the publications are case reports or case series, but there's no randomized control trials at this point that support the use of ribavirin. The combination of ribavirin and favipiravir is also being used, but it's important to take into account that they can have a lot of adverse reactions. And at this point, stampedine is being assessed actually and has been used as off-label for Lassa virus. Convalescent plasma for Hunin virus, that is the one where it has been really studied, decreases the mortality from 16.6 to 1%. So the Hunin virus is the causative agent for Argentinian hemorrhagic fever. So there's actually, it is recommended to treat with convalescent plasma if somebody acquires Argentinian hemorrhagic fever. The only risk is that if the patients receive convalescent plasma after day 8 of presentation or day 8 of symptoms, they are at increased risk for developing the late neurologic syndrome. As I said before, this usually presents with cranial nerve palsies and can have ataxia, and usually presents month after recovery, and it can last several months until it recovers. There's a lot of monoclonal antibodies that are not commercially available right now, but are being studied for arenaviruses. And the last one that I'm going to be talking about, the viral hemorrhagic fevers, is the Crimean-Congo hemorrhagic fever. And I don't know if you saw in the news, but there has been an increase of cases in Iran right now with Crimean-Congo. So we can see the distribution of the Crimean-Congo hemorrhagic fever that is in Europe, Africa, and Asia in a lot of different countries. You can see this is from the WHO, but you can see the countries in red have 15 more CCHF cases reported per year. Those countries that are in orange, they have 5 to 49 CCHF cases reported per year. The cases in yellow, they have less than, they have virological evidence that there's the virus, but they don't actually have more than 5 cases a year. And the ones that are in very light yellow, they have the presence of the vector that is a tick, and we're going to move to it, but there's no cases. But they have the potential basically to have cases. So it's something to keep in mind. And basically here we have, so CCHF or Crimean-Congo hemorrhagic fever is transmitted by Hyeloma genus ticks, that the most common one is the Hyeloma marginatum. And you can see how it changes in size. So the larva from 0.5 to 1 millimeters up to 7 to 15 millimeters. So they can become very big, but you can see in some of the pictures, very, very small and hard to detect. And as I said before, this is a Bunia virus. So again, this is the exception to the rule. You know how we were saying that most of the viral hemorrhagic fevers, and we're still going to follow the same criteria, and we're going to ask all the questions up to 21 days before, because we want to make sure that we actually assess for other viral hemorrhagic fevers. But for Crimean-Congo hemorrhagic fever, the incubation is 3 to 7 days. It is longer if it comes from tick exposure, and it's shorter incubation period if it is from a bloodborne transmission, for example, in a healthcare setting. So basically, for Crimean-Congo hemorrhagic fever, we have a pre-hemorrhagic phase, a hemorrhagic phase, and a convalescent period. So the pre-hemorrhagic phase is usually 1 to 7 days, where the patients are going to have fever, headache, myalgia, dizziness, GI symptoms, and upper body hyperemia. Again, this is very, very non-specific. The hemorrhagic phase are usually going to have easy bruising, bleeding from mucosa, and from being prone to sites, the convalescent period can be prolonged, and there's no relapses that are described in the literature. And you can see the images of some of the ecchymosis of this patient, and obviously the patient was obviously having epistaxis, and how it has a mortality of 5 to 50%. There's some scores. This is a severity grading score that is not specific for Crimean-Congo hemorrhagic fever, but it's actually used to predict poor prognosis. And you can see that all the things that were taken into account are age, presence of bleeding, hepatomegaly, organ failure, elevation of AST, ALT, LDH, as well as leukocytosis, elevated PTT and INR and PT, as well as low platelets counts. And usually when the score is less than 4, the patients, most of them will have 0 mortality. However, in those patients that are diagnosed with Crimean-Congo hemorrhagic fever and they have a severity grading score of more than 9, they usually have 100% mortality. So maybe if we have a patient, it's worth doing the severity grading score. Also to keep into account that a lot of the places where they have cases, they don't have a lot of medical resources. So it's hard to say whether this grading and the outcome would be the same if they were treated, for example, in a unit in the US or in a high income country in Europe. But this is what most of the publications say and how they relate the SGS score with prognosis in Crimean-Congo hemorrhagic fever. So how do we prevent it? So the most important thing is like, okay, I love to travel. I like to go hiking when I go to other countries. Okay, avoid exposure to ticks and actually do some tick treatment if you see a tick. For nosocomial infections, we need to use appropriate PPE. And there were one vaccine approved in Bulgaria in 1970 that was thought to be effective and was an inactivated virus. But at this point, right now, there's not a single vaccine approved for prevention of Crimean-Congo hemorrhagic fever. However, there's many vaccine candidates that are very advanced on the road to approval. Again, ribavirin is going to be an off-label use. And as well as monoclonal antibodies, there's some that are in phase 1 and phase 2 research. Treatment, supportive therapy as for everything. Ribavirin and favipiravir, again, off-label use. Monoclonal antibodies, and there is some data suggesting that those patients with higher about 4 severity grading score, that the use of methylprednisolone can improve the outcome. So based on all of the things that we discussed about viral hemorrhagic fevers and all the information that we learned about our patient that you probably don't remember because we discussed it earlier on, your patient likely has a viral hemorrhagic fever, malaria, typhoid fever, cholera, or other. And the answer in this case, I was like, yes, the patient has probably high risk for Lassa based on the exposures. That being said, malaria is not off the chart only because the patient used malaria prophylaxis. But, you know, we always need to check for malaria. We cannot rely on typhoid fever, right? There has been several outbreaks. So it's something that we actually do need to test for, as well as cholera. We're not doing prophylaxis for cholera at that point, at this time, even though some patients actually do get the vaccine. But the big thing is that we still cannot get one over the others. We still will have to test for all of the above. So quick summary about the viral hemorrhagic fevers. We have a lot of different viruses that can cause hemorrhagic fevers. The ones that we discuss are the ones that could be considered a category A pathogen. So we have flaviviruses. Again, dengue is considered a category A. Yellow fever is not considered a category A. We need to always think about what is the vector and the reservoir, as well as the geographic distribution. The vector is mosquitoes. Do we have a pre-exposure prophylaxis for yellow fever? There is a vaccine available, a lot of candidates for dengue. Do we have any medical countermeasures available? No. That being said, there's a lot of, all of these are RNA viruses, so there's a lot of ribavirin off-label use for RNA viruses. Is there any evidence of human-to-human transmission? The answer is no, and the case fatality rate is less than 1%. So usually we're not going to get these flaviviruses patients in our bio-containment units. They can be in a regular floor room. Filoviruses, that is a different story. So we have Marburg and Ebola. The reservoirs, we have bats and other mammals. Do we have any pre-exposure prophylaxis? Yes, and this has an asterisk. In the US, we only have pre-exposure prophylaxis or vaccine approved for Zaire Ebola virus. In Europe, they have other options as well. We do have some available medical countermeasures approved for Zaire Ebola virus and phase 2 and phase 3 for Marburg and Sudan Ebola virus. There is an evidence of human-to-human transmission and has a mortality of over 50%. So these patients are going to be in a bio-containment unit. For arenaviruses, we have Lassa and South American hemorrhagic fevers. The reservoir are rodents. We do have a vaccine for Argentinian hemorrhagic fever. Also for Argentinian hemorrhagic fever, we can use convalescent plasma, but ribavirin plasma and favipiravir has been used for the treatment of other arenavirus hemorrhagic fevers. There is evidence of human-to-human transmission, and the mortality varies from 1 to 20% for Lassa and 10 to 40% for South American hemorrhagic fevers. And then for viruses, we didn't talk about Hanta because everybody's a lot more familiar with hantaviruses. But when we talk about CCHF, the vector are ticks and blood of infected animals. And for hantaviruses are rodents. Pre-exposure prophylaxis, we don't, but there's a lot of vaccines under development, medical countermeasures. For CCHF, again, off-label use of ribavirin. There is evidence of human-to-human transmission for CCHF. It's unlikely for Hanta. However, the hantavirus in Argentina is thought to have human-to-human transmission. So that's why I'm saying unlikely instead of a robust no, because there is some concern for human-to-human transmission in some of the viruses. And the case fatality rate is 5 to 50% for Crimean-Congo, 5 to 15% for hemorrhagic febrile syndrome, and 40% for the cardiopulmonary Hanta syndrome. And that's the one that we will see in the US. So the mortality is pretty high. So again, we talk a little about bio-containment units and what the regional treatment centers are. There's a lot of literature about how to staff and create a bio-containment unit. Our unit at Denver Health is staffed by hospitalists with consulting services from critical care and ID, but the primary team will be hospitalists. And then basically the infrastructure, we need some physical conditions, we need some specially trained staffing, and we need some technical stuff such as PPE, and we need ultrasound that can be inside the room, portable X-ray, telemedicine, glide scopes, CVVH, Lucas device, and ECMO that are usually in the bio-containment unit. So when do we activate? And this has been discussed potentially for high severity, to cause large-scale outbreaks, to cause nosocomial infection, and scarcity of available medical countermeasures. Again, this is the kind of PPE that we use. We use category 8 West and negative pressures. And this is some pictures from some of our drills in the bio-containment units. And if you want to hear a little about the current outbreaks, we do have polio, like for wild polio 1, there's some outbreak or cases in Afghanistan, Malawi, Mozambique, and Pakistan. And then the cases that we had in the US were the circulating vaccine-derived poliovirus 2, but there's also that one in many countries. And the one to think about right now is Marburg, as I said before, in Equatorial Guinea and Tanzania. And there were an increase of CCHF cases in Iran. Lassa is endemic for Nigeria, so they continue to have cases. If you want to know more about Marburg with a little more detail, there's a YouTube video right there that we posted last year when there was a couple of cases, and now again, that you can go to. So big take-home points. Clinical presentation is very non-specific, particularly early in the disease course. So what is key to actually making a diagnosis and thinking about it is the epidemiologic history. So again, travel, occupation, exposure, immunization, prophylaxis. And so you need to think about it in order to diagnose it. You don't want to put this patient in a shared room or not actually be using the correct PPE if there's any risk. If you're in doubt, you can always call your local public health expert or national experts, and they will guide you in the next steps to identify, isolate, and inform. Most of the viral hemorrhagic fevers are category A and B pathogens that are usually caused by Arenaviruses. We didn't talk about pox viruses because everybody became very familiar with Mpox during the last year, but those are DNA viruses. as you already know. So for viral hemorrhagic fevers, the ones that have vaccines are Ebola, Hunin, and yellow fever. For orthopox virus, we have Jynneos and ICAM. Again, we didn't talk about pox, but it's one of those that we would consider using a bio-containment unit, at least we did before 2022. We're going to do supportive management on all of those patients. There's some non-specific medical countermeasures. And again, anecdotal evidence of ribavirin and favipiravir for Arenaviruses. Consider remdesivir for piloviruses. They were better than nothing, but they were not as good as Inmazeb. But if we have a case of Ebola or Marburg, it's okay to start with remdesivir. And again, non-specific for DNA viruses, we can use cidofovir and briumvidofovir against a lot of the double-strength DNA viruses. Again, we didn't talk about pox viruses, but that's something to keep in mind. And then more specific medical countermeasures for Ebola Zaire, we have Inmazeb. For Hunin convalescent plasma, and for small and mpox, we have tecovirimat. The big thing is, like, if you're in doubt, just suit up. And then you have time to shed all those extra layers of protection that you put on. There's a lot of resources that you can access, and I'm happy to share all the slides. And thank you very much. I'm happy to answer any questions. These are all resources. So
Amazing. Thank you so much, Dr. Frank, for that incredible talk. I think we have a few minutes for any questions. So if you want, please unmute yourself or direct chat me or put it in the chat for everyone to see.
Hi, Dr. Frank. Thank you for that amazing talk. I'm Angie. I'm one of Manier's co-chief presidents. I guess I just had a question about the interactions of different outbreaks and epidemics. And I know you mentioned in 2020, like there wasn't as much of a need for the Hunin vaccine, it sounds like. So I was wondering, maybe that had to do with something with the COVID outbreak and people wearing masks more often to prevent inhalation of like COVID, but maybe that also helped. And I know we've seen that on like a local level in New York, that, you know, our influenza numbers and our seasonal coronavirus numbers were obviously so low comparatively in the past few years. So I was wondering if you could speak to like the interaction of, you know, our response to the COVID pandemic and all of these other, you know, more local epidemics.
So there's a difference between emerging infectious diseases and some of the things that we see every year that are seasonal,
Right.
such as influenza and common colds that actually went down during COVID. The reason why Argentinian hemorrhagic fever went down was because of the immunization. So every person that lived in the area actually got immunized. So at some point there were no cases anymore. So they stopped immunizing, thinking that maybe there were not going to be more cases. They gave it 2 years, cases went up, they started immunizing again. And that is because you can have a scratch, you can scratch your arm and just get, there's some areas and some of the farming vegetables and stuff that they can scratch people and they can have some of the excreta there. So there's different ways to actually acquire that are not inhalation alone. Same with a lot of the filoviruses, right? It's not necessarily airborne, it's the contact with blood and bodily fluids. So I think that, and again, when you think about Ebola, all the bodily fluids that were tested in a patient with Ebola will have virus, tears, sweat, everything. So the use of a mask alone will not decrease it. That is not to say that wearing masks, particularly during COVID, did not decrease. Like we saw a decrease in numbers of influenza and a lot of other seasonal infections. So personally, I'm still wearing a mask on a plane in like crowded places because I don't want to get a cold or anything else. So I still continue to wear, but there's a difference of where when we're not talking about droplet and we're talking about like contact with bodily fluids, the mask won't actually do a thing. But you know, people are washing their hands more and using hand sanitizer. So there's a couple of things that probably can be prevented, but all these emerging infectious diseases are not necessarily happening in high income countries. So, you know, there's some things that are harder to achieve with the common measures that we're doing, but I don't know if that answered your question.
No, it definitely did. I was just thinking about, you know, all the different, you know, ways that we can transmit these illnesses. So thank you.
Thank you, Dr. Zhang. And thank you, Dr.
Frank. Thank you so much for this excellent talk. I found it extraordinarily interesting. My question for you revolves around dengue, and specifically some of the recent efforts and new discoveries in dengue vaccination. Obviously, dengue wasn't a primary focus of this current talk, but it was mentioned as one of the possibilities for your case presentation of this patient, and since you did focus a lot on diseases within South America and Latin America, I wonder, clearly dengue exerts a huge burden on the health of Latin America, and it's been very resistant and difficult to create vaccinations. Some safety problems with early vaccinations, but recently, a new discovery of and rollout of a new vaccine, Qdenga, which is recently approved by a few governments in South America. What do you see in the future for dengue vaccination? Do you think that that this will continue to be sort of a stymieing problem, resistant to a solution, or do you think that actually there may be some promise for dengue vaccination and greater control over that disease?
I think that the vaccine is great, and some countries are trying to start giving the vaccine to most people. I think that COVID not only brought masks, but also brought a lot of hesitancy against vaccines, and it became a lot. So I think that we're encountering some other challenges on doing mass vaccination in endemic areas that we didn't have before COVID. Again, I'm all for vaccines, and I even get all the experimental ones that we get in the Bio-Containment unit. So, but I do think that there's a lot of the countries, and it's country by country, that are actually approving the vaccine and giving it out. There's not, for example, it's not approved in Argentina yet. And there have been this last summer's cases in Buenos Aires. That is the first time ever that they have community cases in Buenos Aires and not people that just returned from the north of the country. So I think there's going to be a bigger push to do mass immunizations. And I think that a lot of the South American countries, they have a more paternalistic healthcare system where if given for free, people are going to get it. But there are some other countries such as Brazil and, well, in Argentina, vaccination is mandatory. You cannot renew your ID without vaccine, so it's going to be easier. No matter what side of the political spectrum you are, people, they all got the COVID vaccine, for example. That was not part of the argument. But there's some countries where there's a lot of anti-vax movements, and one is Brazil, and they also have a lot of dengue cases. So I wonder what challenges they're going to encounter to do the mass immunization. But I think it should come. It has a lot of healthcare burden, but also there's a lot of reinfections as well. So I'm hopeful, but I think we're gonna encounter challenges that we wouldn't have maybe 5 years ago.
Thank you so much.
And I don't have the right answer, right? I'm just like, it's a feeling.
Thank you, Dr. Frank. I think we'll do one last question in the chat from Dr. Kwok. How can poor countries pay for vaccines, especially as we're talking about, the emerging dengue vaccine? It's a great question, Dr. Kwok.
Well, I don't have the right answer. Again, I don't do healthcare policy, so it's like I wish I could say they're going to give it for free, but I don't know. I think that the WHO is very good at working with vaccine manufacturers to actually have a quota of free or low-cost vaccines that are distributed by WHO. So, but it all depends on the vaccine. So, for example, you know how I told you the Vavio vaccine is available in Europe, and WHO has the vaccine, yet it wasn't offered for the Marburg outbreak recently. So when I said that we have some monoclonal antibodies that we could use in the US, there's a limited number of doses that are available. So those were not sent to Equatorial Guinea. They're still in the US in case we're repatriating cases. So, sorry, I thought my dog was going to start to bark. So, I think that the WHO has this, they work very tightly with vaccine manufacturers to try to make them available. But there's also some of the vaccine manufacturers that have partner with other vaccine manufacturers in other countries. So during COVID, there were a lot of vaccine that was made in India and in China. And so there's other countries also working on it. So she's actually a big German Shepherd, so I'm surprised she's not barking all the way out.
Dr.
So-
Esper, I agree. I think your dog, Dr. Frank, is sensing that we are over time. So,
But I don't have the right answer. I think WHO works with companies to make it available, but I don't know how to make it other than that just make it as an agreement through policy.
thank you, Dr. Frank. I know we have a ton of other questions for you.
Happy
but
to answer via email if
Yes.
you send them to me.
Perfect. Or you could forward them to me and I'll be happy to send them over to Dr. Frank. But thank you, everyone. Thank you so much, Dr. Frank, for doing this on short notice. It was a pleasure learning from you. And thank you, everyone, for joining us today. And we'll see you next week for another Department of Medicine Grand Rounds. Have a great day. Thank you again, Dr. Frank.
Thank you.
Bye, everyone.
Thanks, Gabby. It was amazing.
Thanks, Alfred.
I'll talk to you soon.
See ya. Bye.